Buongiorno a tutti, siamo qui con la dottoressa Julie Fendall. Oggi con lei parleremo delle problematiche post-partum e di come l'osteopatia può aiutare a risolvere o a dare un adeguato supporto alle mamme dopo appunto il parto per le problematiche che si possono andare a presentare. Hi Julie, we are here with Dr. Fendall. It's a pleasure to have you with us, and today we would like to have your opinion as an expert on the postpartum trouble in the women. And the first question is this: when did you start to have in your practice this kind of patients?
Oh gosh, a very long time ago. I actually worked with pregnancy right back when I was a student at university. So right from my second year clinical practice, I went into a particular clinic that was run one afternoon a week, treating pregnant mums, postnatal mums, and infants. So 42 years ago is the short answer.
Yes. The second question, very common question, is which are the most common presentation?
I think most usually you'll be treating women who are still in some level of discomfort after delivery. And that might be women who've had discomfort through pregnancy and it continues. It might be as a result of the birth, probably particularly vaginal deliveries and very extended vaginal deliveries, perhaps with the use of instruments. But you can also see women after cesarean sections as well, and they will present with anything from across all sorts of delivery. They will present with anything from musculoskeletal pain, pelvic floor pain. Sometimes, though, it is related just to the manner of the delivery. Rather than it being pain, it is actually their emotional state which needs support, perhaps because of protracted labor or difficult delivery. And that is most likely to come to your attention because you're unraveling what happened during the birth in seeing the baby. And then the mother starts to explain how she's feeling and what's happening specifically for her. And that really needs to be, they really need to be cared for.
Okay, and another question related to this particular topic. And have you ever had some patient that comes to you after the delivery with problems that at the first doesn't seems related to the delivery, but after an osteopathic evaluation you realize that are and which kind of problem in this case?
Yes, absolutely. You might have a woman who presents to you not necessarily immediately postpartum, but sometime later. And as you start to evaluate through the history and looking at what's going on for them throughout the musculoskeletal system, you realize that it's something that was related to the delivery itself. But the presentation that they might have might seem unrelated. It might be something related to their digestion or the function of their bowel. It might relate to ongoing situations with menstruation, or it may be something which seems totally unrelated. You know, it might be something that they present with in a completely different area of the body. But it's in the examination and in trying to relate when it commenced, and actually as they're unfolding their history, they will tend to say, actually, I didn't have this before I was pregnant. I didn't have this before my second baby.
I agree. Yeah. It's very common also in my practice. And well, thank you, Julie. The next question is a little bit more uncomfortable for us, because you know that as osteopaths we have all such a big ego sometimes, so it's very easy to say, well, I treated all of these patients with this kind of disease and all went well and we are fantastic. But Sometimes this doesn't happen. And I would like to have your opinion, of course, related to this topic, when, in your opinion, we can be very effective, and in which cases we cannot be so effective.
Oh, I think that's difficult to quantify as absolutes, but what I would say is that it's really important to keep reevaluating. So I would anticipate when I'm looking at a patient that I would want to be seeing change of some description from the very first treatment, but certainly reevaluating within the second or third to ensure that the complaint that the patient has is actually changing. But also thinking, is osteopathy the correct approach here? So, or is osteopathy the correct approach alongside something else? So I would say that could be alongside physiotherapy, where they will be working more specifically internally with the pelvic floor. I don't do internal work, but I think that osteopathy has the opportunity to be doing lots of things affecting viscerally without necessarily doing a procedure per vagina. But I also think that working alongside their other practitioners, so having situations where they've already seen pelvic floor physiotherapy, for example, which hasn't been sufficient, then osteopathy can have a part to play there. But I think it's really making sure that you've got the correct diagnosis. So you're working to check whether this is something that actually needs further gynecological intervention because of prolapse or something of that nature, or whether this mother needs assistance from a psychological point of view, further support than we can give her. We can assist with perinatal or postnatal depression, but I wouldn't like to say that it's necessarily going to be the overall thing that they should be receiving osteopathically.
I totally agree. Yeah, right. Right.
Yeah.
And other 2 or 3 questions, no more, Julie. I don't want to. Usually, as osteopaths, we continue to talk about the relationship between the mom and the baby. And you know that in treatment is very common to say that the condition of the baby sometimes is related to the condition of the mom. And so you see sometimes that, for example, in the practice, when the mom comes, just a part of the baby, the environment, the behavior of the baby change, and when the mom is not there, it's different. Okay. Do you think that also there is the opposite? The behavior of the mom and the symptoms of the mom in such a way depend on the baby situation. And so you need sometimes to treat the baby to not to fix, but to, increase a little bit the level of health of the mom.
I think it can work both ways, absolutely. And I think to always consider them as being connected with one another, particularly the earlier after delivery. And I think the variety of situations where you would want to be treating both can be enormous. I treat a lot of situations in relation to feeding in particular. So I'm treating the baby, both in terms of advice, but in terms of mechanics, oral mechanics, those sorts of things, but also situations for the mother that relate to milk production, the ability to support the baby, the ability to feed. So you're actually assisting the mother from an osteopathic point of view there. But there is also the situation, if you've got a mother who is highly anxious, where her respiratory mechanism, her digestive mechanism, her central nervous system or autonomic nervous system is really heightened, helping to treat her, to soothe and calm all of that in her body is going to make a difference in her relating to the baby. And vice versa, a baby who's very agitated, if you can calm the agitation in the baby, either through their respiration, through their autonomic nervous system, whatever it is that needs assistance, soothing the baby, assisting their well-being, means that the mother has got a baby that she can potentially be less anxious about, manages to feed better, manages to settle and sleep better. So there are very much interactions between the two of them. And I will often choose to treat the mother instead of the baby in a particular treatment, or vice versa. And also the interaction of who needs what in each appointment as well needs to be taken into account. Yes, absolutely.
Yeah, yeah. So sometimes you consider mom and the babies as a sort of unit, and
yes, they are a unit. They're certainly interconnected, definitely. And understanding that for the whole family, and understanding it for the father as well, or the other primary carer, because they need as much support as the mother does, and acknowledging the role of the other parent is really important. Or sometimes the other primary carer is actually a grandparent. So being able to support them and guide them with what needs to happen for the mother and the baby can be useful, and helping with their role has an important part postnatally, definitely.
great. Other two questions, not the last one, but almost the last one is, as you know, we work more or less in the same way. So in our practice, we decide to use some kind of techniques and to do not use other kind of techniques. I would like to know, in particular, in these cases, so talking about mom, why did you decide to use some kind of approach and to exclude from your practice other kind of approaches? I know that there are not rules, of course, but
no,
why
there aren't rules.
this decision?
I have just used over many years, I've used what are described as indirect approaches, but they're balanced ligamentous tension, osteopathy in the cranial field, myofunctional release, those sorts of things. But I've just found them to be highly successful. They make phenomenal changes within the body physiology, and they do it in a way which is completely empathetic with the mother's body or with a patient's body. There's no imposition from outside. There is always monitoring change within tissues so that there is compliance and ease, so that the effect for the mother tends to be very gentle, but deep and profound. So you can get really big changes in many of the systems, even though your contact is from the musculoskeletal system. So if you're dealing with a woman who has had an epidural, for example, your contact onto the mid to upper lumbar spine will have a profound effect all the way through the pelvis, the central nervous system, the spinal cord, the dural membrane, cerebral spinal fluid, the effect on the central nervous system and brain, and on the autonomics. And I just find it's a way of getting in really deeply into all systems.
Great. Last question, dear Julie. In the end of September, you will be with us to run a course about this topic. Would you like to present in a short way the course, and especially why in the end of the course you will dedicate a part of the course to a sort of clinical approach with cases?
So the courses I run generally, but with you, are in part lecture format, but a lot of practical rehearsal on each other. They will cover a lot about the pregnancy itself and the things that will have occurred through pregnancy that we need to pay attention to postnatally, but also looking specifically at the birth processes, what interventions have occurred for the mother, for the baby, and the effects postnatally. And then what we'll try to do is, in a clinical setting with mothers who are postpartum, actually have the opportunity for the students to be treating women postpartum with me supervising and other tutors. I'm hoping you perhaps they're helping to tutor as well, so that we can actually discuss the types of things that we've looked at during the course. Think about the history that we need to have. Think about the management of the patient as well, because taking care of a woman has to be done very sympathetically and empathetically postnatally. We have to be very respectful of everything that's gone on for them, and understand that there are situations where the experience that they've had might be traumatic. Some women may have had a beautiful birth that they feel very comfortable about, but many women experience things which they weren't expecting. And learning how to handle and support them effectively is really important, as well as the hands-on. Yeah, I look forward to it.
Thank you, dear Julie. Thank you for your time, and well, see you in the end of September. Okay.
Fantastic. I look forward to it. Thank you, Lele.